Hello, and welcome to the series Metabolic Acidosis and Chronic Kidney Disease, Evolving Management Strategies. Today's session is the final session of the 3 weekly modules and is entitled Novel Approaches for the Management of Metabolic Acidosis. My name is Dr. James Matera, and I am the moderator for today's program. I'm the Senior Vice President of Medical Affairs and the Chief Medical Officer at Central State Medical Center in Freehold, New Jersey. I am privileged to be joined today by Dr. Vandana Mathur, who is president of Mathur Consulting and on staff at the Clinic by the Bay in San Francisco, California. Here are our disclosures for today's talk. We will be discussing some off-label use for the treatment of metabolic acidosis, including sodium bicarbonate, potassium and sodium citrate, and an investigational agent named Verimer. This program is approved for 0.5 CME, CNE, CPE, and AAPA credits. These are provided by the North American Center for Continuing Medical Education, LLC, an HMP company, and we're supported by an educational grant from Tracida Incorporated. Today's learning objective is we want to assess the potential clinical implications of novel approaches for the management of metabolic acidosis in CKD. Okay, Dr. Mathur, thank you for our final session today. We're going to talk a little bit about some of the effects of sodium bicarbonate and then spend a little time going over a novel agent that is on the horizon that may help with some of these issues. So this was a study done actually this year, which shows the effects of sodium bicarbonate at a dose of approximately 1.5 to 3 grams per day on the sodium bicarbonate. It was called the Bicarb study. It was a multi-center randomized double-blinded placebo-controlled trial encompassing about 27 sites. The mean age of the population was 74. The estimated GFR was actually quite low, 18 to 19 milliliters per minute per meter squared. And the serum bicarbonate mean was 20 to 21 millimoles per liter. As expected in this patient population, 88% had hypertension, 33%, which is a little lower than the average that we see, had diabetes, and 8% had heart failure. So as far as the sodium bicarbonate dosing, the dose was 500 milligrams TID or a matching placebo, and it was then titrated to 1,000 milligrams TID if the serum bicarbonate remained below 22 millimoles per liter at the end of month 3. And the doses were chosen to reflect clinical practices over in the UK where this study was done. So you can see on the graph there the change in the bicarbonate level, with the bicarbonate patients being in the black dot and the placebo patients being in the clear dots. And over time, you could see that there was an improvement in the baseline serum bicarbonate levels with the administration of bicarbonate.
And it's interesting that the effect sort of attenuates over time, kind of consistent with that, dropping out of treatment. And I think that is partly what happened in this particular study. The patients were non-adherent to some extent.
Yeah, that's a great point, because if you look out at 24 months, it's basically the same. Yeah. And a lot of that probably has to do with dropout, adverse effects, or maybe even just a loss of efficacy that we may be seeing as the patients progress on through chronic kidney disease as well.
Yeah, and the authors made, a really kind of good point here. They were talking about their selection of dosing of sodium bicarbonate for this trial, and and they chose it, as you said, because this was their standard practice, and they felt at the end of the trial that they were probably spot on, because had they gone up higher, they would have had even more non-compliance than they had. So I think they felt justified in their dosing selection at the end of the day.
Yeah, I actually like the composition of this trial. I thought it was very well done.
Yeah.
So how about the safety of sodium bicarbonate? We talk about some of the adverse effects, but are we using a safe medication here? Growing up in an Italian-American household, we all had sodium bicarbonate in the cabinet in a blue bottle called Brioschi. And everybody had that for any dyspepsia you had. You don't see that as much anymore. In Italy you do, but not here. So, when we look at this dose of 1.5 to 3 grams per day that was used in the trial, what were the adverse events that we saw? So if you look at the total number, and it was roughly 457 patients, We had a lot of different things, but look at the GI differences in the line 2. Far higher in the sodium bicarbonate patients than in the placebo patients. And then if you go down also, another one that I want to call your attention to is the cardiac disorders. Again, 32 versus 19 in the placebo group. And in the nervous system disorders, twice as many in the sodium bicarbonate group. If you actually look at metabolic and nutrition disorders, it favored the placebo a little bit more. And then falls, which we're also worried about in our patients, slightly higher in the bicarbonate group. So this also tells us, though, that it's not just the GI that we have to be worried about, although that may be the inherent factor that gets people to stop the bicarbonate. But there may be other disorders, particularly cardiac disorders, that we have to pay very close attention to when using this agent.
Yeah, and this is these adverse events, are kind of reflect kind of the disappointing results of their primary endpoint, which was to look at physical function improvement. And I think with the level of increase in bicarbonate that was achievable with these doses of sodium bicarbonate, there was no significant effect on the physical function. And with these falls and musculoskeletal adverse events that we're seeing, it doesn't look like there was any benefit, and maybe even a little bit of harm.
Yeah, excellent point. That's an excellent point on this study, and just goes to show you so many different things at play here. So what are the risks of alkali treatment for metabolic acidosis? Well, we've talked a little bit about them on the slide, the last slide, but these are well known and they go back many years. This study is from 2015, but certainly the ones that we're primarily interested in is fluid retention. A lot of our patients, whether they have nephrotic syndrome, diabetes, other cardiac conditions, get fluid retention anyway, may make this worse. Their blood pressure, as we alluded to in module 1, oftentimes isn't at the targets that we want them to be, and this may also impact in the wrong direction. They can get pulmonary and peripheral edema with the sodium-based formulations. Here we are telling them on hand 1 to reduce their sodium intake, and on hand 2, we're giving them extra sodium. So a little bit of difficulty sometimes conveying to your patients why they can't eat potato chips if you're giving them sodium bicarbonate. So we also know that a higher sodium intake attenuates the cardiovascular and renal benefits of the ACE inhibitors and ARBs. And those are so essential to what we do and how we treat patients, not just from the renal standpoint, but cardiac standpoints. These medicines were just coming out as I was training. So, I've been living in the RAS inhibitor era. So we've seen how many good things they can do. And I truly think that these are one of the greatest achievements we've had in the last 30 years of medicine. But just giving sodium can attenuate some of those benefits. So we also know, in keeping the world neutral, that if we have bicarbonaturia that we give from giving alkali, and it starts to get excessive, you'll drag some extra potassium out, and the patient can develop hypokalemia, which is also bad. We never want to go to the extremes with potassium. But they can also get hyperkalemia if we start to use the potassium-based formulations, or if you remember our food diagram, they go more towards the alkali-based foods, which tend to be higher in potassium. So all those things have to play in our mind. Our patients are in a positive calcium balance anyway. So these can also impact that by increasing vascular calcification and kidney calcification. And some of these agents can certainly lead to calcium phosphate nephrolithiasis, yet another risk factor for progressive chronic kidney disease. So we got to watch for what we're trying to do correctly to try to reduce the risks of the acidosis. And the age-old question in medicine is the disease worse than the treatment? Certainly in this case, I wouldn't say that, but we do have to be very aware of the things that we may cause by using just basic alkali treatment for metabolic acidosis. And Dr. Mather, I think that really tells us that there's a role for something that we can try to use that may be a little bit more beneficial for our patients.
Yeah, I think clearly there is a gap that could be filled with something that doesn't have some of these downsides, that maybe is better tolerated. We're under treating right now, and I think that reflects the challenges that you've outlined in this slide. So let's talk a little bit now about Verimer. Verimer is an investigational agent that's currently under review by the FDA. It's a polymer. It's a first-in-class hydrochloric acid binder. It is non-absorbed. It's not an ion exchange resin, so it's not like Kxalate, for example, and therefore it's not exchanging acid for anything else, so it's not leaving behind a counter ion like sodium or potassium. And that's, that's relevant in the light of the discussion that we've just had. The polymer selectively binds to chloride and proton and up and down the GI tract, and then excretes the acid through the feces. And then, of course, because HCl secretion into the gut leads to a net generation of bicarbonate, this net removal of acid from the gut yields a net increase in serum bicarbonate in the blood. So in fact, I mean, this drug is really turning the gut into kind of a kidney in terms of its ability to get rid of total body acid. And so it's a novel mechanism by which to treat metabolic acidosis. So this drug has been through phase 2 and 3 trials, and the data I'm going to show now are from these phase 3 trials. There were 2 phase 3 trials. One was a 12-week parent study, which was the pivotal trial, and then a long-term extension study, 301E, which was also randomized and placebo-controlled and blinded. So 217 patients with GFRs between 20 and 40 were randomized into this trial. There was a little bit of an uneven randomization 4:3 ratio. And they had to have quite low serum bicarbonate, 12 to 20 on entry. The treatment was either Verimer, starting at a dose of 6 grams a day, and which could then be titrated up to 9 or down to 3, depending on the bicarbonate after week 4. And the dose adjustment was also occurring in the placebo group because, of course, this was done in a blinded algorithmic way. And then patients were followed through 12 weeks. And the primary endpoint for the bicarbonate increase was taken at week 12. And then in the extension study, bicarbonate was looked at again for kind of durability of that effect at week 12. And also, interestingly, these studies had built-in physical function endpoints looking at the ability of correction of metabolic acidosis to improve both patient-reported as well as objectively measured physical function. So here's kind of the diagram of disposition. So we see that patients were randomized 124, 93 to the 2 respective arms. There were not very many discontinuations. 119 patients in the Verimer arm and 89 in the placebo arm completed the study. And nearly everybody was analyzed for efficacy. The one patient who was not did not get any study drug treatment after randomization, and so they were excluded from the efficacy analysis. The demographic characteristics were well matched in the 2 arms. Some of the key exclusion criteria for this trial was the goal here was to try to enroll people with chronic metabolic acidosis. If a patient had a clinical diagnosis of an acute acidotic condition or acute on chronic acidotic situation, regardless of their serum bicarbonate, they were excluded. And then the other key one was stable renal function, defined as no increase or decrease in eGFR by more than 20% during the screening visit, and also no history of AKI or worsening kidney function during the 3 months preceding entry into the trial. And because the drug did not have any sodium load, unlike trials where you have to worry about that, the eligibility criteria were pretty de-restricted in terms of enrolling a broad population of CKD patients. So for example, with heart failure, the only patients who were excluded were people who had actual class 4 symptoms in the past 6 months, but kind of all other levels of heart failure patients were includable into the trial. So here we see some of the baseline characteristics of the average GFR ended up being around 28, 29. The baseline bicarbonate was 17. And the patients had the kinds of comorbid conditions that you would expect hypertension in nearly all of them, diabetes in 2/3, LVH in about, half or 40%, and then congestive heart failure in about 30% of the patients. And these studies, by their design, did allow patients who were already receiving alkali treatment to simply just continue on those treatments in the trial. And then the Verimer or placebo was added on top of that in a blinded manner. It turned out that despite this pretty significant level of acidosis, only about 10% of patients were receiving background alkali supplements. And we see, that a lot of them had CHF and LVH and hypertension, and perhaps, those are some of the reasons why alkali was not being used, or perhaps it was used before but had been stopped.
Yeah, and I think that drives home the point that we talked about early on, is that, a lot of these patients come in maybe undiagnosed and alkali therapy wasn't considered. Because certainly if you look at the demographics here of the, the hypertension is almost universal, and the diabetes a little higher than the 50% range. But, classically what we would see in these patients, but yet a small percentage receiving treatment.
Yeah, very consistent with some of the other work that's been done in this area. So here now we're looking at the results of the phase 3 pivotal trial. And on the bottom right, I'll start there, is simply the change from baseline in serum bicarbonate over time. And a couple of things to notice here. One is that there's a sort of an immediate separation between the placebo, which is in the blue, and the active, which is in the red treatment. And as early as 1 week, there is a significant difference in the serum bicarbonate. And the trajectory of the curve with the Verimer is that the slope, increases, the bicarbonate continues to increase through about weeks 4 through 8, and then it stabilizes and remains stable through week 12. All of these time points ended up being statistically significant, but the week 12 was the primary endpoint that had a p-value of less than 0.0001. And the overall increase in bicarbonate here in the Verimer group was about 4.5 milliequivalents per liter. If we look at panel A on the left side, we look at what was the composite primary endpoint. So this was a dichotomous endpoint, which looked at the percentage of patients who achieved a 4 milliequivalent increase in bicarbonate, or normalization starting from their baseline of 17 on average, or getting into the normal range. And so here we see that 59% of patients in the Verimer arm and about 22% in the placebo arm met that primary composite endpoint definition. And when we look within each component of that composite, the percentage on the Verimer was significantly higher than the percentage on placebo. And that's what you see in the forest plot there in panel A. Panel B looks at different cut points of serum bicarbonate. So if you were to look at the percentage of patients who had a 3 or more increase, or a 4 or more increase, or a 5 or more increase, across all of these different potential cut points, the percentage of patients who achieved these increases in bicarbonate was significantly greater for patients in the Verimer arm. And if we look at patients who achieved a 2 or more increase, that's close to 80% of patients who were treated. And I think this is relevant because, as we had talked about before, every 1 milliequivalent increase in serum bicarbonate seems to affect risk. So even people who didn't get to 4 milliequivalents could potentially derive some benefit from having their metabolic acidosis corrected based on the literature that has been published thus far. So what about long-term treatment? So this table basically shows the achievement of the 4 milliequivalent increase in serum bicarbonate at week 12 versus week 52, and the mean change in bicarbonate at week 12 and week 52. And we see that these results are very similar at week 52 compared to week 12, which shows us that there's longevity of this response. It's not a waning response. There's no attenuation of the effect over long-term treatment.
I think that's a key point as well, that there doesn't seem to be attenuation of this out to a year. So I think that's very promising for this agent.
Yeah, I mean, clearly when we treat metabolic acidosis, it's for the long term. Once patients develop it, they don't usually get better.
Yes.
Now here are some data which I personally find very exciting from this trial. which is the physical function data. So I think, as we treat these people with CKD, we kind of accept the fact that they're older, they have many comorbid conditions, their physical function isn't very good, they have trouble getting up from the exam table, they have trouble walking down the hall. So, and I think sometimes we think that's probably, not much we can do because this is multifactorial. So I think what this trial found is that, correction of metabolic acidosis as just a single intervention significantly improved physical function. So this here is the KDQOL physical function domain, which looked at things like patient-reported limitations with walking a block, walking several blocks, climbing a flight of stairs, lifting, bending, stooping, just the daily activities that people do. And we see that starting at week 12, and then even more so at week 40 and week 52, there is this significant improvement in the way patients felt about their physical function. So their limitations were significantly decreased. And at week 52, this difference between placebo and active was over 12-point decrease, 12-point difference in KDQOL. And we know from, all of those ESA anemia studies that, trying to even get to a 3-point difference in physical function on these KDQOL subscales was very challenging in those trials. The MCID, the minimally clinically important difference is between 3 and 5 points for these KDQOL scales. So this is a pretty, significant difference clinically, not just statistically.
Yeah, I agree. And I think that that's a great sign here. We didn't see that in some of the bicarbonate trials. And I think that based on all the things we talked about, the impact of metabolic acidosis, this is refreshing to see that.
Yeah, and I think, maybe, the amount of bicarbonate increase in this trial was just so substantial, 4.5, 4.7 milliequivalent increase. And I think it was possible to get there because patients continued to stay on treatment. They tolerated it well, and the drug was effective. So now we look at objective physical function. So this was using the repeated chair stand, which is something that I think as nephrologists, we don't see that much in our literature, although it's increasing, but widely used in the geriatric field to assess physical performance is 5 times repeated chair stand. We simply have patients get up, up and down from the chair 5 times, and you time how long it takes to do that. So that was a very simple test that could be standardized across all of these clinical sites. And what we see here is, like with the patient-reported physical function, their objective physical function also improved, and improvement here is, a lower number. So that means you're doing the test faster. So in the red arm, in the Verimer group, we see that the chair stand test time decreased by 4.28 seconds. And it was basically, very stable in the placebo group after a little bit of improvement early on with a highly statistically significant result. But we might look at this and say, well, what does this, really mean from a clinical standpoint? So I think one of the pieces of information that we can think about here is, what happens to a normally aging population in the community. So in aging patients, people who are when patients age between 60 and 69 years and age by 20 years being 80 to 89, that's associated in normative data with a loss of 3.4 seconds in the chair stand. So what we're seeing here is, more than the amount of physical function decline that one observes with, 20 years of aging in an older population. So I think that helps us to understand, what this may mean from a clinical standpoint for a patient. And it, and it goes along quite well with how the patients then self-reported their own functioning. Okay, well, what about adverse effects of the Verimer? So let's remember that this is a non-absorbed drug. So we probably would not expect, terrible side effects. And we might expect some GI adverse effects, just based on its mechanism of action and what it is. So here we're looking at data from the 12-week pivotal study and then the blinded placebo-controlled extension study, 40 weeks in duration. So overall, a year's worth of adverse event data. And if we look across the top, we can see that there were 4 deaths during this time frame. They were all in the placebo arm. Serious adverse event rates were similar in the placebo and Verimer group. Certainly no increase in Verimer relative to placebo. adverse events related to study drug treatment was higher in the placebo arm than the Verimer arm. And if we look at kind of what were the types of adverse events we were getting in the pivotal study, the 12-week study, there was a higher incidence of GI adverse events on the Verimer group, 17% versus 9%. And the main difference came from diarrhea, which was 9% versus 3% here. These diarrhea events were typically short-lived, so asked patients, and none of them required any treatment interruption or discontinuation. So patients seemed to resolve their diarrhea kind of on their own as they continued to dose with the same dose. And when we look across on the other side at the 40-week data, it becomes clearer that the diarrhea event rates became the same in placebo and active, 6.2 and 6.3%. And here we also see flatulence, which made it to this 5% event level in the placebo arm, 6.2%, and the Verimer group, 7.1%. So fairly similar looking, adverse events in terms of the GI profile. The other one that we notice here is hyperkalemia occurring in 10% in the Verimer group, 6% in the placebo group in the left, and on the right, a lesser difference, maybe 11.1 versus 14.3%. When the potassium was looked at from an objective standpoint, not adverse event, this kind of investigator, defined hyperkalemia. When we looked at the potassium levels based on laboratory analyses, there was no difference in the mean changes. There was no increase in the percentage of patients with potassiums over 5, 5.5, or 6 in the Verimer arm versus placebo. So I think on the balance, it looks like probably no effect at all on potassium. And otherwise fairly, well-tolerated GI profile.
Dr. Mathur, I agree with you. It looks to be a well-tolerated drug for the most part. And, I think this is a good slide to show us some of those things for the safety of this drug.
Yeah, and I think the other thing that was interesting here in the AE profile is that the renal impairment type adverse events, again, this is investigator-defined renal impairment, was about half that in the Verimer group compared to the placebo arm. And we can see this better in a pre-specified analysis that was done looking across this 1-year treatment experience at death, dialysis, and 40% decline or 50% decline in eGFR. I think we're going to see that here on the next slide.
Yes.
So here's the Kaplan-Meier curve. And again, this is a pre-specified analysis. This was not one of the primary endpoints of the trial, but rather an analysis to look at, what happens with CKD progression in this trial. And what we see here is a 12% DD50 or death dialysis 50% decline in eGFR in the placebo arm in the blue, and a 4% rate of DD50 in the Verimer arm, a relative risk reduction of about 65% over the 1-year treatment course, and a p-value of 0.0222, which was also significant even after adjusting for urine albumin creatinine ratio and diabetes, which are the two big, other risk factors for CKD progression. So I think, what we can take home from this is that in non-dialysis dependent patients with CKD and chronic metabolic acidosis, 12 weeks of treatment with Verimer significantly increased serum bicarbonate, with 50% of patients achieving a normal serum bicarbonate starting from a mean of 17, 56% achieving an increase of 4 milliequivalents or more, and 59% achieving that composite, which was one or the other of the above. The Verimer effect on serum bicarbonate was rapid. It was observed within a week and sustained over 52 weeks of treatment. And the Verimer was well tolerated, safe, and effectively corrected the metabolic acidosis in patients with CKD. And really, surprisingly and importantly, improved how patients felt and also how they functioned.
That's a key point, because the better we can have our patients feeling, the more we can work on some of those modifiable risk factors as well.
Yeah, and I think it makes them more keen to take the drug. They're taking a drug that makes them feel good versus one that makes them feel bad. I think it can really help our efforts in getting them to be compliant with what we prescribe.
Yeah, and I think the data here is very promising for this agent. I'm looking forward to seeing more in the future.
Yeah, I agree.
So thank you for joining us for our program today. If you have any questions, please submit them to the Submit a Question tab located at the right-hand navigation bar. One of our expert faculty will respond with to your query. To receive your CE credit for today's program, please complete the evaluation located on the right-hand navigation bar. You will then be able to and print your certificate. We hope you enjoy this series as much as we've enjoyed presenting it for you on metabolic acidosis and chronic kidney disease. And on behalf of Dr. Mather and myself, thank you for joining us, and we'll see you again in a future seminar. Thank you.